Yeah.
Okay, so I've started the recording and you can go whenever.
Okay. This is Asan Hussain. I am a assistant professor at the Department of Ophthalmology and Visual Sciences in Halifax, Nova Scotia at Dalhousie University. And I shall be speaking to you here about the diagnosis and management of epiphora, so the tearing patient. So first of all, I'll just show you this picture. Um, Let you have a think of what you're looking at, but I'll just spare you the agony of being picked on in a live lecture. But what you're looking at here is up the nose. I'm doing an endonasal DCR. And as you look at the screen towards the left is the middle turbinate. That bulbish kind of lighting up structure is the lacrimal sac with a light pipe. And you can see the sort of Fraser sucker or suction at the lower part of the picture. So the important thing here to realize is that when you're doing a DCR, the fundus of the sac is just below the insertion of the middle turbinate. So you'll have to open that area. Otherwise, you may get a failure, or you'll get a sump syndrome. And I'll let you look that up, SUMP, but that can cause recalcitrant tearing in patients who have not had sufficient opening of their ostium. So, evaluation of the tearing patient. This is something I enjoy greatly. I think lacrimal surgery and my lacrimal practice is very enjoyable and straightforward, and it's very methodical, which I like about it. So the first thing is that it's quite common for a patient to complain of a watery eye. In fact, if you ask people, I tell patients, if you ask anyone over the age of 65, out of 10 patients, the numbers say that at least about 4 or 5, maybe 50%, may complain of some degree of tearing now and then. For some patients, it's significantly bothersome. And the first thing to be aware in your history is what the patient actually means by tearing. We published a paper in Journal of Craniofacial Surgery on terms in oculoplastics. So epiphora is simply put the overflow of tears onto the cheek. So if the patient doesn't describe the tears running on down their cheek, they don't have epiphora. They may be getting some watering or some reflex tearing, but you need to ask them in the history certain specific questions. So before we get to the history, just as a broad approach to patients, you should know that in infants and children, the commonest cause of nasolacrimal duct or lacrimal drainage issues are congenital nasolacrimal duct obstruction or congenital anomalies of the lacrimal drainage system. In young patients, so between the ages of 20 and 45 or so, the more common causes of tearing are trauma and fractures, and also scarring from infections such as herpes simplex. Then as you get older, towards middle age, you can start getting higher incidence of dacryolyths and cicatricial disorders, such as by patients wearing contact lenses all their life that can cause changes in the conjunctiva. And then over 60 is where classically you start to see the patients with the idiopathic primary acquired nasolacrimal duct obstruction, which is the commonest thing that we see requiring a DCR. And of course, also your involutional eyelid malpositions. Why do I put them into those 4 groups? Because in a young patient between 20 and 45, they should not be getting nasolacrimal duct obstruction. Something odd's happening until proven otherwise. So you have to really be pushy on the history about trauma, about infections, about any history of sinus surgery, and you probably have to image them or do some further investigations, which we'll talk about at the end. So the history, what do I say to my patients who've come in, sat in front of me with saying that I've got tearing? I first of all say, well, what do you mean by tearing? Are the tears running down the side of your eyelids, the inner part, the central part, down your face? Is it one or both eyes? Are they equally bad? Is it worse indoors compared to outdoors? So in a patient who's got nasolacrimal duct obstruction, it really should be present equally, both indoors and outdoors. But in a patient with reflex tearing, you'd think it would be worse when they're exposed to environmental agents. I also ask them about burning, itching, or greenness, or any dry eye symptoms. Do they have any history of eyelid surgery, any sinus problems, any history of nasal surgery or trauma? Do they get sinusitis, so nasal stuffiness? That can cause obstruction of the inferior meatus and nasolacrimal duct exit. Important to ask about glaucoma drop use. So glaucoma drops, if used over a long time, especially the types with preservatives in them and the benzalkonium type drops, can cause lid dermatitis and cicatrizing conjunctivitis. And we don't know why these older ladies present with punctal stenosis. You may have seen these patients in clinic with really tiny puncti. There's been some studies done. Michael Yoon published a paper in OPRS. Really, we think there's a drop that's causing this, but we don't know what drop it is. Somewhere, or maybe a preservative or some other ingredient. If you have a patient with a history of facial trauma, you'll have to do some imaging. Always ask about facial nerve palsy. So did you have a history of facial nerve palsy? Because they maybe end up with some weaker orbicularis function. Their lacrimal pump may be compromised. You also want to ask about systemic features like nosebleeds, any masses that they've had, any masses around the eyelid, or any skin or history of lung problems, because conditions like sarcoidosis and GPA can also cause nasolacrimal duct obstruction. And be aware also that in the facial nerve palsy, the possibility of crocodile tears, so through aberrant regeneration. So once I've done my history, then I move on, of course, to the drug history, and you'll be aware of the certain drugs such as the taxonomeres, like docetaxel, radioiodine, certain chemotherapy drugs which result in canalicular or nasolacrimal duct, or both stenosis or scarring. Very important to be aware of that in the drug history. Now, move on to the examination. So let's say you have some idea, even before getting to the slit lamp, of what you're dealing with. I always start systematically. So I push the slit lamp aside. I look at the patient's face, look for any asymmetry. I check for facial nerve function. I look for any frank eyelid malposition. I look at the position of the lower and upper puncti. Are they kissing? If they're kissing, touching each other, kissing puncti is actually a defined condition, and that might be the cause of their obstruction. And you can pull the lid away and you'll find that the punctum should sit better. Look at the size of the punctum. Is it stenosed? Is it everted? Is it obstructed? There might be a plug there the patient never knew about. Do they have any accessory puncta? Look for a fistula on the skin, very important. Look for a trichiasis or dystichiasis. Look for any lesion like a molluscum. That can cause irritation of the conjunctiva and cause tearing. Look at the, and then as you get on the slit lamp, you'll be looking at the lashes, as I said. Look at their blink, look at their tear breakup time, look for corneal staining, evert the lids, check for follicles, check for puncti, check for follicles, check for papillae. I also check for globe malposition before I got to the slit lamp, and asking the patient just to look up in a worm's eye view, because proptosis, a very subtle proptosis, or a negative vector might be the cause as well. So once you've done that, of course, the next thing that we normally do is doing the syringing. So again, terminology. People say syringing, they say flushing, they say irrigation. They have lots of words to use. I would ask you to probably look up that article in JCFS about terminology. The most accurate term to use is syringing. You're not flushing. Flushing is termed for a wound. You're not irrigating either. You're actually syringing through fluid, through a canaliculus. So that's what you're actually doing. And what you're doing, and there are some excellent videos out there on YouTube of how people have done syringing. But one thing to bear in mind is that you should pull the canaliculus laterally to straighten it. Be aware that the first 2 millimeters of the drainage system is vertical. So you'll have to go straight down, then horizontal in the next 10 millimeters. If you can, try to do a little probing with your the cannula, depending on the type of cannula that you have. But if it's uncomfortable for the patient, don't. I know Richard Allen describes using a Bowman's probe in the office, but I find that it can be quite uncomfortable for the patient, but the patient tolerates it. That's great. That will help you. And then when you're syringing, what are you looking for? Well, first thing you're looking for is, of course, is there reflux? If there's complete patency, try to assess if it's 100% or if you're getting some reflux as well. The reflux, is it coming from the same site that you're irrigating, or sorry, syringing, or is it coming from the opposite side? Are you seeing mucus? The presence of mucus is very predictive of a nasolacrimal duct obstruction. And if you have pain, you should stop. That means the patient has some sort of inflammation there. And I would always say to you, never syringe a patient who has dacryocystitis. You will just cause pain, and it will be blocked, of course, but all you do is cause pain. Just as a side note, if you have a patient with a lacrimal sac mass, which you think is a dacryocystitis, of course, the history is important in terms of onset, but if it extends above the medial camphal tendon, have a low threshold for imaging because that might well be a lacrimal sac tumor. So once you've diagnosed the cause, the most common causes that we see are either reflex tearing through dry eye, which can be evaporative or aqueous deficiency. Then it can be a problem. Second most common is usually involutional changes, such as eyelid malposition or punctal malposition or weakening of the lacrimal pump, such as with facial nerve palsy. And then finally, with actual problems within the drainage system, which could be scarring. If you get a soft stop within the canaliculus, you're dealing with a canalicular obstruction. Or if you get no flow to the throat and complete reflux, you're really looking at a nasolacrimal duct obstruction. There are some other tests people do, such as a fluorescent dye disappearance test, which we do in children. They're not going to let you syringe their nasolacrimal ducts, and you shouldn't even try. I would say put the drop of fluorescent in on both sides, 2% fluorescent, leave it for 4 to 5 minutes, and then use one of the lamps, I forget the name of it, as an ultraviolet lamp they use, which magnifies the eye, but also lets you see the presence of dye. So the presence of dye on one side compared to the other tells you that there's probably obstruction. In children, before you take them to the OR for congenital nasolacrimal duct obstruction, which needs probing, always check that they have puncti. It's very embarrassing for everyone involved if you bring a patient into the OR for probing and tubes maybe, and they don't have any puncti. So whatever happens in that room with a child crying and screaming at you, you have to get a look at their eyelids and check that they have puncti before you take them to the OR. So let's say let's say you have a patient who you can't tell, they have patency in their syringing. There's no evidence of dry eye. Their eyelids look fine. So what you're dealing with a functional type of tearing patient. So some investigations, people have done Jones tests where they, Jones 1 and 2, very rarely performed these days, where you actually try to retrieve fluorescent from the nose. It's extremely uncomfortable for the patient and somewhat blind in its, unless using an endoscope. I routinely do endoscope my patients with nasal endoscopy. I have a tower in the office, which I use if I have any suspicion of a mass or something happening in the nose. And I use that to see if there's any fluorescent in the nose. I don't do a formal Jones. Another thing you could do is refer a patient for either a DCG, which is a dacryocystogram, or a dacryoscintigram. So very important to be aware of the difference. A dacryocystogram is where the radiologist will put a tracer onto the eye and syringe through with a little cannula, the tracer through the drainage system. So that's like typically what you're doing with your syringing in a clinic. That is not a physiological test. That is an anatomical patency test, because it just shows you whether it's traveling through through an artificial test, which you may have achieved as well. What you really need in a patient, you're thinking, excuse me, of a of a functional obstruction is a dacryocystogram, where the tracer is placed on the eye, but then they take serial X-rays and they watch the dye travel through the drainage system. And that's what you need for your functional patient. And those patients who have a positive DSI will do very well usually with a DCR. And you can do a DCR in those patients. So really, what I would also say in my final closing for this case is that many patients have a multifactorial presentation. So, you may have a patient with a bit of dry eye, maybe 70% obstruction of their nasolacrimal duct, and also some evidence of, eyelid malposition. So what do you do? Well, in my practice, at least, I start conservative. I say, look, let's start with your simple things. Let's put you on, treatment for dry eye, blepharitis, whatever. And then I usually say to them, if you have no improvement, depending on their age and how symptomatic they are, I might jump to the DCR, or I might say, let's do your eyelids first. It's a discussion between you and the patient, as long as you tell the patient that they have a multifactorial presentation. Fixing one will not fix their problem 100%, but we can take it as they want. We can do it from conservative to most involved, like the DCR, or the opposite way around. You want me to do the DCR, which may well give you the most improvement that you want, but it's more invasive. And in an older patient, you may not want to do that. But that's a discussion. So always discuss with your patients what their objectives are with your treatment. Don't treat every case the same. That's my piece of advice. Okay, that's the end of that case. Gabby.
That was really great. I tried to come up with questions, but I'm having trouble. You answered all of them as I was writing them down.
Okay.
The only thing I can think of is I've been reading a little bit on IgG4 related disease and nasolacrimal duct obstruction, and that's like, it's pretty far-fetched. And so if we want to edit this out, that's perfectly fine as well. But obviously when we're in the OR, if the surgeon notices that there's something off in the tissue, they'll send it for pathology. But I wanted to know, do you think that there's any role for routinely sending tissue when we're doing a DCR, even when the tissue looks normal?
Yeah, that's an excellent question, because there's actually papers written on this subject. I can't remember the authors of both papers, but I do know Francois Coder's paper. They argued against routinely biopsying tissue unless you think there's a problem there. But there's another group, I'm trying to think, I might be wrong about that actually. I think it's maybe Francois Coder who actually said do biopsy. Sorry, my apologies if that's the case. But anyway, that's there's people who argue both ways. In my practice at least, I only biopsy if I think the tissue looks abnormal. So if I'm doing a DCR and the lacrimal sac looks thickened, I will definitely do a biopsy. And I have had at least one patient who I diagnosed lymphoma of the lacrimal sac just with that, and systemically they were fine, thankfully. But she had no other symptoms. But to routinely biopsy all tissue, well, the argument is, well, if you do that, it gives you tissue available for future immunohistochemistry and other fancy tests that might help find the etiology of nasolacrimal duct obstruction. As you know, we don't know what causes the idiopathic form. But then there's other people who say, well, you're just creating more work, and it's costing the system money. And I think both arguments are valid, but in my practice at least, I just do it on abnormal tissue. Yeah, and wherever you see abnormal tissue, you should take that. And again, take a good amount of tissue for your pathologist. Yeah, it's a good question.
Thank you.
Awesome.
Oh, yeah. I just wanted to add that at the end, actually. This is just a picture of, as I was doing the DCR of inferior turbinate, just showing the scarring at the exit of the nasolacrimal duct. And, it kind of makes you think that there's probably an external process going on which is causing this, as such, idiopathic NLDO. We've done a study on GERD related to this, which were hoping to enlarge the study. But anyway, it's a great topic to investigate further. Yeah. I don't know if you can add that at the end, Alex. Yeah,
Yeah, I can.
that's great.
Awesome.
Okay, I hope that was good.
No, that was great. Good,
Exa-
good on your end, Gabby.
Okay, good.
Yeah, so we'll do some more another time.